Let's start with HEENT, head, eyes, ears, nose, throat. What are you looking for? Well, the ears, you can do an otoscopic exam. Some nurses feel comfortable with this. For you, you will just be doing the hearing tests, the assessments. When you look at this picture, the baby in the middle is actually having a neonatal hearing assessment. You're going to learn more about this when you're in OB. When you look at the bottom right corner, this is a hearing test for a young child where we put the headphones on and it's computer generated. The child is listening to instructions, and as they point to things, the decibel level of the voice is going to change, and that's one way to do it. Now, when you go to chalk, they're doing the same form of hearing test that you did when you were a kid. You ask the child to raise their hand when they hear it in one ear or the other, and you just plot the results. When we look at the throat, you may be looking at the throat. What I like to tell the kids, if they're old enough, is pant like a puppy dog, and you can go ahead and you can tell them how to do that. And that way you don't have to use that tongue blade so invasively. Because the reason you're looking at the throat is they may be post-op. You need to be looking for swelling and bleeding. They may be coming in complaining of a sore throat, in which case you have to take a culture. And just a little clue, when you are reaching back to do the culture and the kid starts to gag, really get a good look. You need to use a pen light, or you can grab the ophthalmoscope off of the wall as your light source and look at the back of the throat. We'll discuss a little bit more about what can go wrong when we discuss respiratory in week 2. On the mouth, you're basically looking at their teeth. How many do they have, and what condition are they? Believe it or not, you are going to see dental caries in some very young children. Some of them even have silver caps. When we look at the eyes, basically you're looking at the pupils. Now, depending what this child is in for, you will be doing a more aggressive exam, more than pupils. If they have a cellulitis, you're going to have to look at the lid. You're going to have to open the eye. If they have conjunctivitis, you need to pull the lid down and take a look at how red it is and what kind of drainage. For the nose, well, good luck. These kids have really snotty noses. And so what you're looking for is the drainage. There might be a foreign body, in which case you're just going to do a quick glance. You're not going to go digging in for it. That's going to be the nurse practitioner or the physician's job. But you get to help hold while they use an instrument to be able to open up the nair, reach in, and pull out a foreign body. Another thing that you're going to do for the eyes is test their vision. And you have to make sure that you use the correct chart. And so you see the chart on the bottom left, that is a chart for an illiterate child. And it may not be that they're illiterate, period. It may be that they don't speak English. And so what we have is universal pictures, and we want them to be able to say what those are. And if they can't even determine that, we will use the E chart, and all they have to do is point the directions of the lines for the E. On the top right is the standard Snellen chart. So the child is going to stand 20 feet away from the chart, first reads it with both eyes, and then you cover one eye, then the other, and you record. And the numbers on the left will tell you what their vision is, 20/20, 20/40, 20/100. The one in the middle that has the yellow lines and the green bubbles. Now, some of you may not actually see those colors, but this is the Ishihara test for color blindness. So if you don't see that, perhaps you are colorblind. And color blindness tends to be in males. Let's look at the skin. What are you looking for here? So once again, remember, start looking at the skin the second you lay your eyes on the child. Does the child look pale? Does the child look yellow? Does the kid look dehydrated? What is the turgor? Does this child have any kind of rash? And that's going to prompt you to start asking the parents, where did the rash start? What did it look like when it started? How did it spread? Where did it spread? When you look at the variety of pictures that I have here, the baby on the bottom right is actually jaundiced. The baby above, when you see those dark spots, those are actually called Mongolian spots. You need to remember this because when you're assessing a baby and they have these on the buttocks, they can be anywhere. They can be on the hip, they can be on the buttocks, they can be on the leg, on the back, and they do look like bruises. You do not want to accuse a parent of being abusive when you see these because they are a birthmark. Similar to the one on the far right. That's a strawberry hemangioma that's quite large. We hope that that'll go away on its own, and if not, we laser it after the baby is about 1 to 2 years old. Don't get me wrong. You do need to look for bruising, but you need to be able to determine a Mongolian spot, which is kind of a blackish blue, and it doesn't blanch, from a bruise, and a bruise will blanch. Let's move on to the heart. Essentially, what we want you to do is be able to count the rate and the rhythm. So is the rate within normal parameters? And you will receive a vital sign sheet that you can put into your ID badge for reference on the various age groups on what's the normal heart rate, respiratory rate, and blood pressure based on age. So is the rate normal and is the rhythm regular or not? Murmurs, if you go to chalk and you are in the cardiovascular ICU and you have a child who has a variety of congenital heart defects, you will get to hear murmurs. But for the most of the students in the class, they're going to have to be pointed out to you. We do need to check their pulses. So we check the larger pulses. You're not going to do a radial pulse on a newborn. You're not going to do a pedal pulse on a newborn. We're going to do central pulses. So on a newborn, we do the femoral pulses, and then we do the brachial pulses. The most important thing is there equality of the pulses, side to side and upper and lower? This is very important in the young child. In addition, the blood pressure. Is there a disparity or a difference between the blood pressure in the upper and lower extremities? And this is important when the child has a congenital heart defect. Does the child have circumoral pallor? So when you look at this word circum, that means like circumference, only we cut it down. Oral is the mouth. So what you're looking at is around the lips. So it's the outside part of the lips. Is it pale or is it dusky? When we talk about dusky, it's a sort of a purplish color, and we look in the mouth. So when a baby is hypoxic, when a young child is hypoxic, when a congenital heart kid is hypoxic, they're going to have dusky mucous membranes. We can also see clubbing early. Now you're used to seeing clubbing or hearing about clubbing in somebody who has COPD, right? Well, the only time you're going to be seeing clubbing in a child is going to be a child with a congenital heart defect. Possibly somebody who has bronchopulmonary dysplasia that hasn't been well cared for with oxygen, they may have clubbing, but that's not going to show up until they're about 4, 5, or 6 years old. So don't be looking for clubbing in a newborn. They're not going to have it.